where are the challenges in us managing patients with Barrett's esophagus? So where are the challenges? And the challenges are summarized very nicely right here, where you have two patients that look about the same. They have the same size, non-dysplastic Barrett's. It's not too big, but it's not too small. So we can't just say it's a regular Z line, but we could, it is significant findings. And they are all young patients who are going to need a follow-up for a very long time. So who is going to need a very close follow-up and who does not? Do we know it at this point?
This will definitely give a lot more information than what you already know.
That's right. So, and what is this is the tissuecypher from Castle Diagnostics. And if we could
so these are two patients, both non-dysplastic Barrett's esophagus. You know, fairly smaller segment, 3 centimeters and 4 centimeters. The trick is you just really do not know who is going to progress versus who may progress to either high-grade or esophageal cancer. So the one on the left here, and these are actually real patients, fake pictures, real patients out of our data. The one on the left was deemed high risk with tissuecypher. You can see here that they actually progressed to high-grade dysplasia in 2.7 years, when we would have normally seen this patient back in most likely 3 to 5 years per the guidelines right now of having non-dysplastic. The one on the right, though, has still remained progression-free that was deemed low risk with tissuecypher score, and we're about 7 years out now on that patient too as well. So this just gives a pretty good, accurate understanding of who is going to progress from non-dysplastic, indefinite or low grade, and who will also not progress from that stage too as well. So who is going to and who is not going to.
Because right now, correct me if I'm wrong, we're operating in the dark. We don't know who is who. And I think tissuecypher might provide us with that additional information. And there are some advantages to that. This is the information comes to us from a regular biopsy. You don't need anything additional. You just take biopsies as you normally would. And then there are multiple parameters going to be analyzed. But as much as I love our pathologists, there is variability. As we all know, there is data supporting that the way things are read are variable. So another advantage that this is the finding based on AI-driven model, and it takes human variability out, which is also an important findings, I think.
Yep, absolutely.
Precision medicine.
That's right.
For patients with Barrett's, so it'll help to alleviate some of the worries that patients have, and also maybe decrease the endoscopy interval. That if you know that you have a lower risk, you may not be as aggressive in terms of follow-up.
And your management, when you initially see the patients, you don't need to change how you biopsy or where you biopsy, right?
That is correct. Yeah, so it's just based off your standard pinch biopsies, routine EGD. You don't need to put them into a special, container or jar or swab or brush. It's just based off your standard thing that you're doing today. So you don't change one thing you do right now.
And what we're analyzing is what we're getting is an analysis of several biomarkers and tissue architecture. So we get this comprehensive report of where these patients' sort of molecular disturbances are at the time when you biopsy them.
Yep.
Because of that, sampling doesn't play a role in determining those changes in the biomarkers.
Yeah, that's correct. I mean, we still want to have people try and follow the Seattle protocol as much as possible and get as much tissue as possible. That's just, in the guidelines. However, we don't need to have a lot of tissue to analyze with tissuecypher. If you give us one pinch biopsy, one tissue block, we can actually run it against the AI that's looking at 9 different biomarkers, as well as the tissue architecture and the actual orientation of those cells within the histological sample. So that's the important thing, is we can almost take out a lot of that risk that could potentially be involved of not being able to get the exact high grade or cancer within that specimen.
Well, that sounds great.
Excellent.
Thank you so much.
Thanks, guys.